All right, let's just jump right in. This is going to be a high-speed, high-yield guide with one single goal, getting you through your radiology exams. We're going to cut through all the noise and focus only on what you need to know to nail those questions.
You know that feeling, right? You're staring at this absolute mountain of revision material. The exam's just around the corner, it feels like there's an endless amount to learn, and the pressure is definitely on. But listen, what if I told you there's a smarter way to do this? A way that doesn't involve trying to cram every single detail into your brain.
So here's the secret. Success on these exams, it's not about having a photographic memory. Not at all. It's about pattern recognition. It's about building a solid mental framework that helps you spot the patterns, connect the dots, and just systematically arrive at the right answer. And that's exactly the framework we're going to build together right now. Okay, so here's our game plan. First, we're going to lay down the core strategy. Then we'll blast through some high-yield sprints in neuro, peds, and the abdomen. After that, we'll tackle those classic exam showdowns, the this versus that questions. Then we'll connect the dots with systemic clues and syndromes, and we'll wrap it all up with the one final rule that makes everything click. Sound good? Let's do it.
All right, first things first, our core strategy. I want you to think of this as the foundation for everything else we're going to cover. This is your go-to problem-solving framework for pretty much any case they throw at you. It's like your diagnostic Swiss Army knife for exam day. And you know what? It starts really, really simple. The very first question you should always ask yourself when you see a lesion is this thing cystic or is it solid? That's it. That's your starting point. From there, we just work through the steps. We analyze its location, we look at its morphology, its shape and features, and then finally we hunt for those specific clues from the modality, like the all-important MRI signals. And that last step, looking for modality clues, well, that's where MRI really steps into the spotlight. You absolutely have to master signal characteristics. It's non-negotiable for the exam. So let's do a quick rapid-fire drill. This is going to be pure high-yield stuff you just need to know cold.
Okay, T1 bright signals. What are they? The big ones you have to remember are fat, melanin for melanoma, subacute blood, that's your methemoglobin, and protein-rich fluid. You've also got slow-flowing blood and laminar necrosis on that list. Seriously, burn these into your brain.
Next up, what's bright on T2? This one's a little more intuitive, actually. Just think water. Anything with a lot of water is going to light up. So that means fat, obviously water itself, edema, and here's a big one, most tumors are going to be bright on T2.
So what about the stuff that's dark on both T1 and T2? Well, this is the stuff that basically has no mobile protons to give off a signal. We're talking about flow voids in blood vessels, really dense fibrosis or scar tissue, metal, air, and of course calcification. All dark.
And last but not least, what causes diffusion restriction? Just think of anything that's packed so tightly that water molecules can't move around freely. So that's going to be your hypercellular tumors, epidermoids, the classic abscess that's just full of pus and bacteria, acute demyelination, and don't forget CJD.
Okay, theory's done. Time to put it into practice. Sprint number 1, neuro and peds. Let's take that core strategy we just learned and apply it to some classic exam scenarios you're almost guaranteed to see.
Okay, so picture this. You see a pediatric neck mass. You do step 1, is it cystic or solid? Okay, it's cystic. Great. Step 2, location. Where is it? If it's right there in the midline, you're thinking thyroglossal duct cyst. If it's off to the side, lateral, it's probably a branchial cleft cyst. But here's a classic exam curveball. If you see a lateral cystic mass in an older patient, you have to think about a necrotic node, probably from thyroid or nasopharyngeal cancer. See, location is everything here.
All right, this next one is pure, beautiful pattern recognition. It's the neonatal bubble sign. Seriously, don't overthink this one. You see one bubble? Gastric atresia. You see the classic double bubble? That's duodenal atresia. Triple bubble? Jejunal atresia. It's that simple. But if you see bubbles plus distal gas, that's a huge red flag. That could be a midgut volvulus, and that's a surgical emergency. The pattern literally tells you the answer.
Okay, let's keep the pace up. Next sprint, the abdomen, focusing on the liver and pancreas. And here, we're going to see how being a good detective and combining the imaging with the patient's story, their demographics, is an absolutely killer tool for finding the right diagnosis.
When it comes to pediatric liver masses, the single most important clue is right there in the question stem, the patient's age. If the kid is under 3, your brain should immediately go to 2 things, hemangioma
or hepatoblastoma. If they're older, say over 5, your differential completely shifts. Now you're thinking about HCC and its cousin, fibrolamellar HCC. Always, always use age as your first filter.
And you know what? It's the exact same story with pancreatic cysts. You have to look at the patient profile. Who are we dealing with? Is it an older woman? That's the classic setup for a serous cystadenoma. A young woman with a big encapsulated mass? That screams solid pseudopapillary tumor. Middle-aged woman? Think mucinous. The who is just as important as the what on the scan.
All right, time for my favorite part, the rapid-fire showdowns. You know these questions, the classic A versus B comparisons that they love to put on exams. We're going to cut right to the chase and focus only on the key features that let you tell them apart, every single time. First up, Crohn's versus UC. It's just 3 things. For Crohn's, think skip lesions, terminal ileum, and fistulas. Got it? Now UC is basically the opposite. It's continuous, it starts in the rectum, and no fistulas. That's it. That's all you need to get the points. Next showdown, neuroblastoma versus Wilms tumor. This one really just boils down to 2 key differences. Neuroblastoma, it's often calcified and it encases the vessels, like it wraps around them. Wilms tumor, on the other hand, rarely calcifies and it loves to invade vessels, especially that renal vein. Just remember this, neuroblastoma encases, Wilms invades.
Okay, let's talk about a classic exam writer's trick. They'll give you one specific finding that's actually the key to unlocking a much bigger syndrome. If you can spot that one piece of the puzzle, the whole question just opens up for you. So let's run through some of those crucial connections.
This slide is all about quick-fire associations. If you see cysts all over the kidneys and the liver, you should immediately think ADPKD. You see an RCC plus tumors in the pancreas and adrenals? That's your VHL. See an AML in the kidney? Your next thought should be to look for lung cysts in tuberous sclerosis. See endocrine tumors popping up? Think men. Neurofibromas and scoliosis? That's NF1. These are your if you see this, then you know it's that connections, and they are easy points on an exam.
Wow. Okay, we have covered a ton of ground really fast, but now it's time to bring it all home. Let's take everything we've talked about and boil it down to one final super important rule to live by. So let's put a bow on this. What we've been doing here, this isn't about just randomly memorizing facts. It's a system. It's all about training your brain to see the patterns. It's about learning to connect the dots between the patient's age, the lesion's location, and its signal characteristics. And when you're in that exam, it's about using all of that knowledge as a weapon to systematically eliminate the wrong answers in those multiple choice questions. That right there is the entire philosophy. So, now you've got the framework. You've got the high-yield patterns locked in. The only question left is, which one of these patterns are you going to spot first when you sit down for that exam? Trust me, you're way more prepared than you think you are. Now go find those patterns.